Welcome back to ENT Shorties. In just a few minutes a day, we unlock the secrets of ear, nose, and throat complaints for you to use today. While your clinic may not offer allergy shots, it is beneficial for you to understand who is a candidate and how immunotherapy works. Immunotherapy is one of the most effective therapies for allergies. Like a vaccine, it desensitizes the immune system to allergens. Over time, adaptation occurs, and the benefits endure after treatment is stopped. Here's what you need to know. Let's just quickly review our options for managing allergies. 1. Environmental control measures. Reduce the triggers for the immune explosion. 2. Medications. Block the immune response in the short term. 3. Immunotherapy affects long-term adaptation and long-term improvement. Today we focus on immunotherapy, or what I call the suit of armor. The treatment mix is formulated from the results of skin or blood testing. In my clinic, we skin test 40 different trees, grasses, weeds, molds, pet dander, and dust mites. A combination of prick and intradermal testing introduces small quantities of antigen under the skin. If histamine is released, a wheal and flare response occurs, signifying a positive result. Histamine controls ensure antihistamines are not in the system and giving false negative results. Saline and glycerin controls ensure these mixing solutions are not causing false positives. After testing is complete, each positive antigen is administered weekly as an injection or daily as sublingual drops. As a brief review, each patient has an internal level of tolerance for their cumulative allergen exposure. Symptoms arise when this tolerance threshold is exceeded. Immunotherapy raises this threshold, and medications block the immune response when the threshold is exceeded. Who is a candidate for immunotherapy? The short answer is anyone with chronic symptoms despite adequate environmental control and medications. Patients with sinus surgery for chronic sinusitis or nasal polyps benefit greatly and may decrease the risk of revisions or recurrences. Mild asthmatics also benefit, but caution should be used for more severe asthma. Over time, allergies typically worsen, and only immunotherapy has the potential to slow this. Younger patients experience long-term benefits, and I generally start immunotherapy at 10 years of age and up. Older patients benefit as well, but caution should be used for severe cardiovascular or pulmonary patients. Who is not a good candidate for immunotherapy? Severe and poorly controlled asthmatics and patients with severe cardiopulmonary disorders. Patients with immunodeficiency or autoimmune diseases. Manipulating the immune response is a theoretical risk for unintended consequences. This is usually a relative rather than absolute contraindication. Use judgment on how to proceed. Anyone taking beta blockers, anaphylactic reactions during testing, or immunotherapy are treated with epinephrine for these reactions. Beta blockers cause unopposed alpha adrenergic effects like increased vascular resistance without a corresponding increase in heart rate. This causes hypoperfusion and decreases the chances of successful resuscitation. In my clinic, we do not give subcutaneous or sublingual immunotherapy to patients using any beta blockers. 3 to 5 years of weekly subcutaneous injections or daily drops administered under the tongue for sublingual are needed to build lasting tolerance and affect immunologic change. Success is determined by symptom resolution rather than additional testing. Both techniques are equally effective, and patients choose based on cost and convenience. After 4 to 5 years, I recommend pausing therapy and monitoring the symptoms. If symptoms immediately recur, therapy is restarted for another year, followed by another pause. Many patients experience 5, 10, or even 20 years of effectiveness with immunotherapy. There are commercially manufactured disintegrating tablets for immunotherapy. I've not seen these used frequently in my practice. Most are designed for seasonal short-term use, as is more common method for providing immunotherapy in Europe. In the United States, it is more common for all allergens to be administered year-round. Let's briefly discuss reactions and emergencies. A future video will explain this in more detail. Itching and swelling at the injection site are the most common local reactions. Pre-anaphylactic symptoms must be recognized and may be very subtle. Patients may say they just don't feel well or have a vague sense of impending doom. Anaphylactic emergency is rare but can happen without warning. Resuscitation depends on the administration of epinephrine as quickly as possible. Do not delay epinephrine for steroids or antihistamines, as this lessens the chance of resuscitation success. You now have the keys to immunotherapy, a highly effective treatment for long-term management of severely affected patients, and the only way to change the natural progression of allergy symptoms. Compliance and consistency is most important for success. Cardiopulmonary patients and those on beta blockers are not eligible. Administer epinephrine as quickly as possible for suspected anaphylaxis.